Hello, today's video may be the most important one we've done so far because it addresses such a common problem, stomach ache in children. So, if you are the parent of a child who's ever complained of belly pain, I want you to listen and listen closely. Now, first of all, our usual reminder, this is general medical advice and applies to just about every case of abdominal pain in children, but not every case. You should always consult your child's individual pediatrician about any specific complaints, especially if the complaints include bloody diarrhea, right lower quadrant pain, fever, persistent vomiting, or sore throat or cough in association with the abdominal pain. Otherwise, tonight's topic is extremely common and it's a huge problem. So in adult medicine, the big C refers to cancer, but in children, the big C refers to constipation. So I have a little joke, but it's not really a joke to start things off. Think about this acronym. Chronic, that's a C. Recurrent, that's an R. Abdominal pain, that's an AP. Almost every time in children, if they have long-term, better, worse episodes of belly pain, it's exactly what that acronym spells out, chronic recurrent abdominal pain. So if you're wondering what the cause is, just remember that and it might help you think about what's going on here. So to get things started, I want to tell you that a lot of kids are embarrassed to talk about this at the doctor's visit. You don't need to be. This is what we do all day long. We talk about poop and it's okay. They've probably gotten in trouble before for potty humor or talking about poop, but at the doctor's office it's okay. I don't want you to be embarrassed, and if you have to giggle a little bit during this video, that's okay too. So to get started, think about some symptoms of abdominal pain in children that could give you a clue that constipation is the underlying problem. One of them is the location. So in children who have constipation, almost every time the location is what we call periumbilical, or around their belly button. Now, I have a friend, Dr. Duncan Williams, who's a pediatric surgeon at Wake Med. Duncan Phillips, I'm so sorry, Duncan Phillips, not Williams, who says that the location of that pain is because there's nothing else under your belly button except poop, right? There aren't kidneys under your belly button. There's not a liver, there's not a spleen, there's not a pancreas, there's not an appendix. It's just intestines. And so if the location is around the belly button, it probably is constipation. Another common symptom is complaints of abdominal pain after a meal. Now, to understand this, think about how things are working. Do you remember when you had a newborn and they nursed or they fed with a bottle, they pooped right after? Well, right after your stomach fills with food, it starts squeezing, that peristalsis. And if it squeezes on top of extra stool, which could be holding in extra gas, that's very painful. So one thing that happens is they start to have this bellyache after they begin to eat, and they have what we call early satiety. That means they feel full before they should feel full. You've put this plate of food in front of them and they should be hungry enough to eat it. It's mealtime. They take a few bites and they push it away. Always, that should be a red flag that they could be constipated, and that's explaining the early satiety. Also, nausea is a common symptom. I want to teach you something one of my professors taught me many, many years ago in medical school, and that is if you have a tubular structure in your body and it is distended or dilated, that always causes nausea. If you've ever suffered from kidney stones, you probably know this. The ureter that connects the kidneys to the bladder, if it's got a stone in there and it's stretched out, severe nausea. Well, it's the same with constipation. If your intestines are stretched out with extra stool and trapped gas, it can cause nausea. So far we have periumbilical, worse after eating, nausea, and then the very obvious symptoms. If the child has difficulty passing the stool, if the stool is large caliber or fat, it's difficult to come out. It requires a lot of straining and work and excess energy, and they stay in the bathroom for a long time. If they're clogging the toilet because the caliber of the stool is so large, that's pretty obvious. If you see a bright red streak of blood on the margin of the stool or when they wipe after pooping, that's pretty obvious too, that the caliber of the stool is so large that as it passed through, it caused a little tear or a fissure, and then that bleeds. And it's a very vascularized area, so it can bleed a lot, and that can be very scary. But just remember, if the blood is bright red, it's near the surface or near the skin, so it's not terrifying as if you had a black or a dark maroon mixed in with the stool itself. This is just coming from the skin if it's on the edge and it's bright red. So don't be too scared by that, but do recognize that that could be a sign of constipation. The other thing is if the poop looks like a little cluster of grapes, little round hard balls all stuck together. Now, a lot of parents at this point in our conversation say, stop, this couldn't be constipation because my child poops every day. Well, my friend Dr. Mann likes to say, you might have 10 train cars that need to leave the station every day. Maybe 5 train cars leave the station every day. That's not enough. The other 5 are still in there and building up and causing problems. So just because your child has a daily bowel movement, it doesn't mean that they don't have constipation or some extra stuck inside. So I want to take you on a trip through your GI tract. We're going to start at the top. When you chew your food and then you swallow it, it's going to go down your esophagus and then into your actual stomach. I want you to remember that every part of your GI tract is absorbing fluid from this swallowed food. The whole entire time it stays in your body, it's absorbing fluid. Well, then from the stomach, after it gets some acid added and churned a bit, it's going to go down to the small intestines and then the large intestines. And it keeps traveling. We talked about the gastrocolic reflex, which is your stomach fills with food or fluid, and it triggers that rhythmic squeeze or peristalsis of your intestines, right? So everything's squeezing, everything's moving down. Well, the very, very last part, right before the poop comes out of your body, is called the rectal vault. The rectal vault is supposed to be empty most all the time. As you're walking around during the day, it's empty. Then you eat a meal, everything moves down, it fills with stool, and you should say, I need to go to the body, and you go and you empty, and then it's empty again all day long. Well, what happens in constipated children is that stool moves down to the rectal vault, but then they ignore that urge to go empty. So it just sits there. And remember what we talked about? If it's dilating, it's probably causing some nausea. It's making those muscles that are all stretched out flabby and less effective at getting the stool out when they need to. And remember, the longer it stays in the intestinal tract, the more time the intestinal tract has to absorb fluid from it. So it gets harder, drier, larger, and more painful to pass. And the muscles get flabbier, so less effectively able to pass it. So it's just this snowball of problems that happens with constipation. So there's a whole lot involved with this, including not only dietary, but a behavioral component. That child needs to learn, I have to poop as soon as I feel that urge. Here's the problem and why a lot of school-age children are chronically constipated. Think about school. If you'll think back to it, you often had to have a hall pass to go use the bathroom. You had to have permission. It was embarrassing. The kids tell me the little slats in the stalls are too big. They're afraid somebody will see them or smell them or hear them. They don't have time. They're embarrassed. They can't relax enough. It might be dirty or smell bad, and they don't feel comfortable enough to poop at school. So a lot of kids who never poop in a public restroom are predisposing themselves to becoming constipated. And so there's not only dietary but behavioral concerns we have. So that means that the treatment, since this is a chronic problem, the treatment has to be a chronic treatment as well. So a couple of things to start with. Remember the gastrocolic reflex. Try to encourage your child to have a bowel movement after a meal. One of my GI professors used to say, every child with abdominal pain should shoot for an AM/BM. That means get up in time to eat breakfast so it'll trigger a natural bowel movement and have a bowel movement at home before you go to school. Then you don't have to walk around all day at school with a stomach ache and holding it in because you'll have already taken care of business before you even got on the school bus that morning. And that's a great idea. They need to learn to be responsive to the urge, to be willing to use public restrooms. Try to encourage their fiber intake. That could be fruits, vegetables, high fiber, cereals and foods and supplements, and lots of water. The softer the stool is, the easier it comes out. And that's what our goal is, soft, skinny stools with a little skinny caliber, not large, hard and fat stools that can hurt when they come out. So there are 2 different categories of medicines because a lot of times it's nearly impossible to encourage children to eat enough fruits and vegetables to effectively soften their stool. So one category is a stool softener. That would be something like Miralax. Generic is fine. It's just a powder that mixes into fluid that draws water into the stool to soften the stool. It doesn't get absorbed into your bloodstream. It's not dangerous. It's not harmful. It's not addictive. It is simply a stool softener. It doesn't make you go, but when you go, the stools are softer when they come out. Now, you can't overdose on it. I don't want you to be scared of it, but you do have to adjust the dose to make it work, and you do have to encourage enough water intake or fluid intake for it to even be able to work at all to soften the stool. The other kind of medication for constipation is a stimulant. Now, before you get too concerned about that word, remember prunes are a stimulant. Prune juice, pear juice, plum juice can all be effective and very natural. This will be something like X-Lax, which is based on senna or Senecot, same thing. It's just got vegetable extracts that help stimulate the stool. Now, another very commonly used stool stimulant is caffeine. So a lot of people just have a big cup of black coffee in the morning, and that stimulates their daily bowel movement, and that's just fine if it works for them. We don't typically recommend large caffeine doses for children, obviously. But with Miralax, when we're treating constipation, if they've been several days without stooling, their belly feels distended on exam, they're complaining of nausea, they're not eating well, they very well may need a clean out, or just like you would do before you had a colonoscopy, they may need to get all that extra stool out. Now, for children, it depends on their weight in how we dose the Miralax, but the basic rule of thumb is if what you've given before isn't enough, they need more. Because remember I said the worst it's going to do is really soften their stool, and they may have some diarrhea for a day or so. So what we would often do is on day one of the clean out of a larger school-age child, for example, we would probably do 8 capfuls. A capful is about a heaping tablespoonful of Miralax into fluid, stir it, and then they can sip it or chug it just to get it all in them if you can that very first day. We also usually recommend 1 X-Lax, the little chocolate chewable squares, on day 1 and 1 on day 2. Now sometimes in extreme cases we also have to go from below with an enema or a suppository, but most of the time you can achieve a clean out from just going from the top with the Miralax and the X-Lax. Then on day 2 of the clean out you may step down to 4 capfuls, and then 2, and then 1 a day for long-term maintenance. Now remember, where we lose a lot of parents is this long-term maintenance. They're afraid to keep it going. They got a good clean out and the child quits complaining of pain. But this is a chronic condition and it can come right back. So you need to be able to communicate with your child. What we would recommend, I call it a pooping diary or a pooping calendar. You can just get a calendar. There are a lot available, and you could have your child write on there a smiley face or a check mark or something that communicates with you every time they have a bowel movement. Because if they've skipped a day, you need to up your dose of Miralax. If they've had 3, you might need to back off a little bit. But don't be afraid of using too much. Only be afraid of not using enough, them getting backed up again, getting stretched out again, painful bowel movements again. And you can imagine if this is happening around the time of potty training, it can really sabotage potty training because that toddler starts to associate painful bowel movements with the potty, and we don't want that to happen for them to successfully potty train. So over long-term management for constipation, you have to titrate the amount of Miralax every single day to get 1 to 2 soft, skinny poops that sort of fall apart in the toilet water after they potty. This is important to prevent all of those symptoms we were talking about before, the periumbilical pain, the postprandial nausea, and feelings of fullness. Even sometimes I'll see worse reflux, because you can imagine if the stomach's slower to empty and it's just sitting there, they're going to probably reflux it a little bit more. So staying on top of this constipation problem is extremely important. I hope this has been useful, and as always, you can always put a question in the comments if you have additional questions about this, but please realize you're not alone, and this is extremely common in school-age children especially. Thank you very much.